Thank you all for being here tonight to discuss a topic that is very near and dear to our hearts here at CMHRC, and that's understanding misdiagnosis and childhood bipolar disorder. Our program tonight is going to cover why skilled practitioners can still miss bipolar in children, ways to distinguish bipolar from other diagnoses, such as DMDD and ADHD, which are often given to kids who actually have bipolar disorder, and what symptoms of bipolar look like in children and how that differs from adults. But before we dive in headlong, I'm hoping you'll indulge me for a moment and hearken back to a previous time in our species' understanding of science and medicine. I want to talk about a time when the prevailing medical wisdom said that babies under 1 year old were unable to feel pain. The belief was based on the idea that newborns and other babies up to 12 months didn't have fully developed pain receptors, and any response babies had to pokes or pricks were merely muscular reactions. As a result, surgeries performed on infants were routinely performed with little to no anesthesia. In fact, often they were given nothing more than a muscle relaxant to keep them from thrashing around during the operation. So, how long ago did the medical community hold this belief? Well, believe it or not, the answer is well into the 1980s. And this belief influenced and dictated treatment. But ask any parent from any era if their newborn can feel pain, and they would tell you yes without hesitation. But instead of listening to parents, confirmation that babies can feel pain required an experiment in which an associate professor of pediatrics at Oxford University put infants aged 1 to 6 days old into an fMRI machine to determine whether or not they were able to experience pain. Turns out they were, and not just a physical response to having their feet poked. They were experiencing emotional pain from it as well. Their brain scans, when compared with those of adults, proved it, and even went so far as to suggest that not only do babies experience pain, but they may be more sensitive to it than adults. This confirming research, incidentally, was published in the year 2015. Okay, so why am I giving you this horrible backstory on pain sensitivity in infants? Well, because there is a clear and direct parallel to what we're here to talk about tonight: misdiagnosis in childhood bipolar disorder. Because up until and including today, February 15th, 2023, a large swath of the mental health care community, including doctors and the medical schools that train them, and therapists and social workers in the graduate schools that train them, continue to insist that children and adolescents under the age of 16 or 18 can't have serious mental illnesses like bipolar disorder. Even though there's a consensus in the literature that bipolar disorder can onset and does onset in childhood, the prevailing wisdom amongst practicing clinicians is that children and teens are assumed not to have these disorders. As a result, the best practices treatments and insurance formularies that govern treatment within most systems often go so far as to flat out prevent providers from even considering the diagnosis of bipolar or writing it in the child's chart. And as for medications, forget about it. If they can't write down the diagnosis, they sure as heck aren't allowed to prescribe for it because there's a predetermined order of prescribing that's agreed upon between providers and insurance companies that must be followed if the provider wants to get paid and the patient wants the medications covered by their insurance. This means that children who actually have a serious illness, like, say, bipolar disorder, have to be diagnosed with something else first and have to take medications that treat those other disorders first before the provider can consider bipolar as a diagnosis or can be authorized to prescribe one of the medications we know works to treat bipolar, although that's not how they frame it. The phrase that's used to describe this process is actually that the child has to fail on the other medications first. I cannot tell you how many times I have heard this said. The child has to fail on those medications first. But if we're misdiagnosing and prescribing the wrong medication for the illness at hand, who's the one who's actually failing? Not the child. So, this is what we're here to talk about tonight: how and why children are misdiagnosed when they have a significant mental health challenge, such as bipolar disorder. That was the first reason. We have a system that is stuck, and individual practitioners are not empowered to meet their patients where they are because they're hemmed in by formularies, diagnostic codes, and reimbursement requirements that discourage innovation and the adoption of new research and treatment protocols. So, how did we get here? Well, believe it or not, there's a swinging pendulum at work. In the 1990s, professionals had started diagnosing kids and teens with bipolar using the diagnostic criteria in the Diagnostic and Statistical Manual of Mental Disorders, known as the DSM. This criteria is presented as universal, although it's written with adults and adult behaviors in mind. By the end of the 1990s and into the early 2000s, children were receiving the diagnosis of bipolar disorder more frequently. Dr. Dimitri Popoulos and his then wife Janice Popoulos published the book The Bipolar Child in 1999, and the authors were featured on an episode of Oprah talking about the need for greater acceptance of bipolar disorder as an accurate and appropriate diagnosis for children and teens. In the years that followed, the pendulum swung back again in the opposite direction, and the powers that be in psychiatry pushed back hard on the notion of diagnosing children with bipolar. This anti bipolar campaign can be summed up by a 2011 book titled, you guessed it, Your Child is Not Bipolar. I'm not kidding. That's really what it was called. And while I promised myself I would not get sidetracked by the problematic characterological framing here in the phrase, your child is not bipolar, and why it is preferable to say, your child does not have bipolar, I have to at least point it out. Shame on the author for that. Anyway, those years of pushback happened at the same time as the lead up to the publication of the latest edition of the DSM, DSM-5 in 2014. So, the American Psychiatric Association, which publishes the DSM, attempted to address this controversy amongst psychiatric experts about whether or not children could be diagnosed with bipolar. The DSM committee charged with addressing mood disorders ultimately concluded that some children did meet the criteria for bipolar disorder that was listed in the DSM, including that they experienced clear episodes of mania. But they concluded that there were other children who didn't meet the criteria of clear episodes of mania because instead they had chronic irritability and temper outbursts. Their conclusion was that those children should be diagnosed with a different diagnosis instead, and a diagnosis was newly created for this express purpose. That diagnosis is called disruptive mood dysregulation disorder, or DMDD. That's right. The DMDD diagnosis was developed specifically to funnel children and teens away from the bipolar diagnosis. But what the committee failed to take into account was the simple truth that symptoms in children often present differently than they do in adults. This is true for physical as well as psychiatric conditions, and that for children and teens, chronic and frequent irritability and temper outbursts can be symptoms of both depression and mania. This assertion that there must be two different disorders because some children meet the existing criteria for bipolar disorder with clear episodes of mania, while other children experienced chronic or frequent irritability and or temper outbursts, was met with a lot of opposition from groups such as NAMI, the National Alliance on Mental Illness, the Juvenile Bipolar Research Foundation, and prominent psychiatrists and psychologists, such as Dr. Ross Green, Dr. Dimitri Popoulos, and Dr. Rosalie Greenberg, to name a few. Researchers from institutions such as The Ohio State University, Wexner Medical Center, University of North Carolina, Chapel Hill, University of Pittsburgh Medical Center, New York University School of Medicine, Johns Hopkins Children's Center, Kennedy Krieger Institute, Nationwide Children's Hospital, and Virginia Commonwealth University examined DMDD and in published peer-reviewed journals wrote, these findings raise concerns about the diagnostic utility of DMDD in clinical populations. And clinicians should not assume that chronic irritability leads exclusively to a DMDD diagnosis. But the adoption of DMDD went through anyway, and it didn't clarify or simplify the diagnosing process. In fact, it muddles diagnosis further by reinforcing the idea that bipolar disorder in children and adolescents is exceedingly rare, when in fact it's not. Bipolar is the sixth leading cause of illness in the world. And if you know that the symptoms in kids and teens can be irritability, angry mood, and temper outbursts, it's not hard to correctly identify. But when we look at the bipolar and DMDD diagnostic criteria, we encounter another flaw in the system that can lead to misdiagnosis. Symptoms overlap and appear in the criteria for multiple different disorders. So, what are those criteria? The primary criteria for DMDD that outlines the observable behaviors includes severe recurrent temper outbursts manifested verbally and or behaviorally that are grossly out of proportion in intensity or duration to the situation or provocation. The temper outbursts are inconsistent with developmental level. The temper outbursts occur on average 3 or more times a week. The mood between temper outbursts is persistently irritable or angry most of the day, nearly every day, and is observable by others. The remaining criteria for DMDD mostly cover things like age of onset, time interval since onset, and other broad time-based parameters, not observable symptoms. So when we look at these 4 primary symptoms, we see that they're all based around irritability, angry mood, and outbursts. But embedded right in the DMDD criteria is a note which reads, if an individual has ever experienced a manic or hypomanic episode, the diagnosis of disruptive mood dysregulation disorder should not be assigned. Okay, so at first glance, this is an important distinction and should be a help to diagnosticians assessing kids. Except again, mania and hypomania can manifest as irritability, angry mood, and outbursts in kids and teens. So if the practitioner doesn't know that, you can see how this helpful note isn't actually so helpful. Because if the provider is looking for manifestations of mania and hypomania, like unrestrained buying sprees, sexual indiscretions, or foolish business investments from a child, then they won't realize that the irritability, angry mood, and outbursts that are being reported by parents are actually mania. More importantly, they'll miss the fact that irritable hypomania in and of itself disqualifies the diagnosis of DMDD from being accurate or applicable. Once again, when trying to figure out the problem of misdiagnosis, we run headlong into the fact that the DSM's exclusion of child and adolescent specific criteria, its format, which results in significant overlap of symptoms among diagnoses, and its fundamental premise to intentionally ignore causes of symptoms leaves practitioners undersupported in making essential distinctions amongst these diagnoses. And misdiagnosis contributes to the delay of accurate diagnosis, which, according to the World Health Organization, for children averages 10 years between when they first seek treatment and when they receive an accurate diagnosis and effective treatment. Delaying a bipolar diagnosis has some very serious negative outcomes, including enduring years of traumatizing symptoms, denying the neuroprotection that comes from proper medication management, delaying the development of appropriate social and emotional skills, and stunting the development of healthy relationships with family and peers. All of this happens as a result of delayed and misdiagnosis. And as a system, we persist in the practices that perpetuate delayed and misdiagnosis, even though we practitioners know that early and accurate intervention is the best tool we have to ensure long term positive outcomes, which makes this whole situation all the more frustrating. Now, while the introduction of the DMDD diagnosis has caused confusion in diagnosing bipolar disorder, it's not the only culprit. Because of the general unfamiliarity with childhood onset bipolar disorder and the overlapping symptoms, providers naturally lean towards other diagnoses, which are seen and applied much more commonly, including ADHD, oppositional defiant disorder, generalized anxiety disorder, unipolar depression, and even conduct disorder, all of which exacerbate the confusion. Since ADHD is one of the most common misdiagnoses assigned to children with bipolar, we're going to dive into how to distinguish the symptoms from one another by looking at a differentiation written by Dr. Charles Popper, who's a child and adolescent psychiatrist and lecturer at Harvard Medical School. In one of Dr. Popper's many published works called Diagnosing Bipolar versus ADHD, which incidentally you can find a link to on the CMHRC website under free resources, research papers, 2015. In this paper, Dr. Popper outlines the differences between ADHD and bipolar disorder, and in it he states that all of the features of ADHD can be seen in mood disorders at times. So ADHD is a diagnosis reached only after ruling out a mood disorder. But this is not routinely done. In fact, diagnosis most often goes in the other direction, with kids diagnosed with ADHD first, and then when those medications again fail by either inducing mania, aggression, or doing nothing at all, only then can a mood disorder like bipolar be considered. As a result, Dr. Popper tells us that there is concern that ADHD is being overdiagnosed and bipolar disorder underdiagnosed in the population of children. So we're going to look at what he identified as the main differences between bipolar and ADHD. But coming up soon, we're going to have a clinical seminar just for providers where we take an in-depth look at each of Dr. Popper's differentiations. So if you're a clinician and interested in learning more, I highly recommend that you sign up for that. But for now, we're going to take a less detailed look at the highlights of how to tell the two disorders apart according to Dr. Popper. Destructiveness. He tells us that children who have ADHD often break things carelessly, while children who have bipolar tend to break things in anger. Duration and intensity of tantrums. The tantrums in children with ADHD usually last 20 to 30 minutes on average, and children with bipolar disorder may continue to feel and act angry for up to 4 hours. Regression. ADHD doesn't include disorganized thinking, language, and body position, but bipolar disorder does include these, and kids with bipolar may often lose memory of the tantrum. Triggers. Children who have ADHD are typically triggered by overstimulation, and children with bipolar are typically triggered by limit setting, such as a parental no. Moods. Children with ADHD do not generally show depression as a predominant symptom. But in children with bipolar, irritability is particularly prominent, especially in the morning, and kids have complaints such as fuzzy thinking and stomach aches. Sleep. Children who have ADHD mainly show difficulty going to sleep. But the disturbances during sleep in children with bipolar disorder include severe nightmares or night terrors, often with themes of explicit gore and body mutilation. Learning. Learning in ADHD is often compromised by specific learning disabilities. And learning in bipolar is more likely to become compromised by motivational problems. New people. Children with ADHD are likely to be pleasant, but hyperactive or impulsive when meeting new people. But children with bipolar often have hostile responses to meeting someone new. Misbehavior, in quotes, because symptoms are often mistaken for misbehavior. We have educational videos for members on our website that outline the distinctions. But in Dr. Popper's article, he refers to it as misbehavior. In ADHD, misbehavior is often accidental and from inattention. In bipolar disorder, behaviors appear to be intentional and provocative. Arguing. The child with ADHD may stumble into a fight. The child with bipolar will look for a fight. Stability. ADHD is chronic and continuous but tends towards improvement. Bipolar disorder symptoms get increasingly more severe or dramatic over the years. Psychosis. ADHD doesn't typically include psychotic thoughts, behaviors, or loss of contact with reality. Bipolar disorder, on the other hand, may include distorted perceptions of reality and emotional events, or paranoid thinking. Lithium treatment generally improves bipolar disorder, but has no or little effect on ADHD. And we know that the stimulants used to treat ADHD can trigger mania, aggression, and significant sleeplessness in children with bipolar disorder. Now, if we line these two sets of symptoms up against one another, it's dense and hard to read, but if we could look at it clearly, we can make pretty quick work of determining whether or not the complex, hyperactive, aggressive, distractible, and irritable symptoms parents are reporting align with an ADHD diagnosis or a bipolar one. So then, if it's so clear, why are there so many misdiagnoses? Well, yes, in part, it's because practitioners aren't taught what to look for. But why aren't we taught what to look for or how to make these differentiations? Well, that's a much more fundamental question, and it harkens back to our mistakes in understanding infants and pain. Misdiagnosis happens because too few doctors, psychologists, therapists, and social workers are taught that bipolar disorder can onset in childhood and that its symptoms look different in kids than they do in adults. To correct this, as an entire mental health care system, we have to be willing to change positions, recognize when prevailing wisdom is wrong, adopt new ideas and techniques, meet our patients where they are, and value the insight of parents. If we start there and get people to adopt this simple research proven point, then we'll be on the path to better, more accurate, and effective treatment for everyone. Thank you for listening to the presentation. We're going to open up to questions now. I'm sure we have quite a few. So Jen, where should we start?